Dear colleagues, in partnership with Nephrology Dialysis Transplantation, NDT, the official journal of the European Renal Association, Markus at Home welcomes Dr. Ali Duarte Garcia in Rochester, Minnesota, in order to discuss optimal glucocorticoid therapy in lupus nephritis, which is the topic of a recent NDT review paper with Dr. Duarte Garcia as corresponding author, which NDT's editor-in-chief, Joachim Anders, Andreas Kronbichler, and I picked as our paper of the month for a detailed NDT Markus at Home webinar. Dear Ali, it's a real pleasure to host you tonight.
Thank you for inviting me.
Dr. Ali Duarte Garcia is assistant professor at Mayo Clinic and received the prestigious prize by the Lupus Foundation of America last autumn, so is well known for lupus research and has also contributed to many, many publications in the field. Together with Gunnar tonight are Professor Kirsten de Groot from Offenbach, Germany, and Professor Hans-Joachim Anders from Munich, Germany.
Well, thank you again for inviting me. So this is an extension of the recent publication that we had in NDT, the review about how to treat or how to optimize the use of glucocorticoids in the therapy of lupus nephritis. So I have no disclosures. So this is the outline of what I'm going to discuss. First, I will go over the historical context of how we arrived to current glucocorticoid therapy practices. I'll review as a couple of small clinical trials. I will discuss a little bit about a project that we have called CLING, and then I'll discuss the findings of a recent meta-analysis that we published last year. How to approach or how to think about long-term glucocorticoid use and discontinuation, alternative glucocorticoid strategies, side effects, and mitigation, and then we will go over the discussion. It looks very packed, but it goes fast. It won't be. It's just a couple of slides for each thing. So I've been a rheumatologist for around 5 years, and as I started to get involved in the field, one of the things that really surprised me was how little we know about glucocorticoids, even though it's the most common therapy that we prescribe for autoimmune diseases. And we use things I'm sure you have heard it many times, like rules of thumb, like use the lowest dose for the shortest amount of time and things like that, but not really concrete data. So even though they have been around for 75 years, we really know little about how to dose them to maximize their benefits and decrease their harms. So in the last couple of years, I've been working on trying to identify either evidence-based practices or design evidence-based practices for the use of glucocorticoids in lupus, but I'm focusing on lupus nephritis because lupus is very heterogeneous, and by reducing it to lupus nephritis, you decrease some of that heterogeneity. So I know a few of you, Andreas and Professor Anders, have been to Mayo Clinic, but when you came to the 19th floor. We are actually in the 15th floor, and when you come down to our floor to rheumatology, and as soon as you leave the elevator, you find what is in the screen. So the founder of our division, the founder of rheumatology, was Dr. Philip Hench, and he received the Nobel Prize for the discovery of cortisone, along with 2 other scientists. And that started and ushered the use of glucocorticoids for autoimmune diseases. He studied rheumatoid arthritis, but then soon after, it started to be used, the glucocorticoids, for many autoimmune or autoinflammatory diseases. So I will start first with the story of how the glucocorticoid practice has evolved. So I mentioned the discovery of the cortisone and the use in rheumatoid arthritis, and soon after, 5 years after that, it started to be used in lupus, both prednisone and methylprednisolone. But in the 60s is when there was the first more detailed reports about the use of cortisone for lupus, and specifically for lupus nephritis. So there was a study done in Chicago where they compare cortisone, an equivalent to prednisone of 10 milligrams to prednisone 50 milligrams. And they had serial kidney biopsies, and they showed that patients who received 50 milligrams of prednisone had less mortality and had less progression to end-stage kidney disease. So really that established the use of glucocorticoids as the standard of care therapy of that age. That was monotherapy back in the 60s, but is when the use of prednisone became, or the steroids became a standard for lupus nephritis. Soon after, very quickly, people started to realize the side effects of the glucocorticoids, and there was a clinical trial. I believe it's the first clinical trial in lupus nephritis using a steroid-sparing agents. Was done here at Mayo by Dr. Donadio, comparing prednisone and azathioprine. This was a negative trial. And then started a series of years in the 70s and the 80s of the NIH trials. First, they compare oral cyclophosphamide to prednisone, to oral cyclophosphamide combined with prednisone with azathioprine, and prednisone alone. And basically, they demonstrated that oral cyclophosphamide combined with prednisone was a more effective therapy. And that's during the 70s, that set up the standard of care for oral cyclophosphamide and prednisone. In the 80s, another series of trials transitioned the oral to IV cyclophosphamide. But in general, they were using the same doses of prednisone, which was around 0.5 milligrams per kilogram per day. In the mid-70s, there were the first reports of the use of methylprednisolone. It was used in patients for lupus, specifically for lupus nephritis, 1 gram a day for 3 days. And I don't know if this is the standard in Europe, but in the US, it's very common to prescribe 3 days of pulses. If you were wondering where this came from, it came from this paper from the 70s. So it's just how it was used the first time and how it has remained. And as I mentioned, in the 80s, there was this transition to IV cyclophosphamide. And then in the 2000s, the introduction of mycophenolate as a non-inferior alternative to cyclophosphamide. Then the prednisone the dose of prednisone used were a little bit higher than before. And then since 2002, when the papers led by Fred Hussion in Belgium, a Eurolupus trial, there has been a constant use of pulses and somewhat lower doses of prednisone. But as you can see in the most recent trials, the multi-target trial in China, or belimumab or voclosporin, all of them use pulses, but there's some variation in the doses. And then the obinutuzumab trial, this is the image that we use in NDT. But now we have a new trial since a month ago or 2 months ago, and they use also very similar doses. So prednisone 0.5 milligrams and pulses of methylprednisolone of 0.5 to 1 gram. Now, so prednisone or glucocorticoids in lupus nephritis are used basically in 2 ways. One is to give pulses, and the other one is to use the oral therapy. And there's some reasoning behind that, not just how it has been used historically, but in terms of how the mechanisms of effect of the glucocorticoids are actioned, they seem to differ when you use a pulse dose and when you use an oral dose. So oral doses affect what is known as the genomic pathway, where the glucocorticoid gets inside the nucleus and then modifies the transcription of many inflammatory genes, a lot of cytokines, and it also has other effects, like it causes apoptosis of T cells and others. But this effect is longer. It takes longer to be to show clinical effectiveness. And in the comparison to the pulses seem to affect more at the at the membrane of the cell, and also affect the ion channels. And I'm sure you have seen it many times in your clinical practice. They have an almost immediate effect. In 24 hours, you can see improvement of the patients. So even though there have been these decades of trials over the years, as you can see, or as you saw, prednisone was used concomitantly. So there have been very few trials where they have explored different doses of prednisone or glucocorticoids, compare a lower dose with a higher dose, or a strategy with a different strategy. There are only 3 small papers or 3 small publications that have done this. And one of them is the my lupus trial. So this trial was done in Europe, published around a decade ago. And they randomized patients with lupus nephritis, 81 patients, to receive 3 doses of methylprednisolone and then mycophenolic acid. This is basically 3 grams of mycophenolate mofetil. And the patients received prednisone 1 milligram per kilogram or half the dose, so prednisone 0.5 milligrams per kilogram, and were followed for 6 months. And over 6 months, there was no difference in complete renal response. But in patients who had the higher dose of prednisone was a more frequent partial renal response, defined as a decrease of proteinuria of 50%. And of course, as intuition says, there were more infections also in the group that received higher doses of prednisone. Now, there was also a small trial in India. This trial was originally planned to have more patients, but was stopped when they did the pilot of 20 patients, and you will see why. So in this trial, it was similar to the previous one. The patients received 3 pulses of methylprednisolone, a little bit of a lower dose of mycophenolate mofetil, but then did the same type of randomization. So prednisone 1 milligram per kilogram versus half the dose of 0.5 milligrams per kilogram. And their outcome was a little bit of a hybrid from others, but basically was a 50% reduction of proteinuria and follow the patients for 24 weeks or 6 months. And in the 1 milligram per kilogram group, they saw a 100% achievement of this outcome of 50% reduction. But in the patients who were receiving a lower dose, they saw that only 40% achieved this outcome. Of course, there were more infections in the patients who received higher doses. So these trials, if you're familiar with the steroid literature, and I don't know if this is as evident in nephrology, but in rheumatology, most of the data about the steroids is always about side effects. You rarely see anything about effectiveness. So these are the reason why I wanted to highlight these trials is because they are also showing effectiveness, not only talking about cardiovascular disease or so on, or infections. And there has been a third trial that was similar to this one also in India. So this issue of seeing, most of the data based on side effects, but very little about effectiveness. And then I was observing that the guidelines were quickly moving about going to lower doses without really assessing what was the effect of effectiveness. We have been working on this project. It's called CLING, Collaborative Lupus Initiative for New Glucocorticoid Strategies. And what we're doing is we're doing a large individual patient data meta-analysis. So we are collecting the data from the trials, the actual spreadsheets, from many trials from the industry, but also from investigator-led trials. And we're going to reanalyze them, the standard of care arms, to understand how prednisone or the glucocorticoid doses that were used impacted the outcomes, the good and bad outcomes. And then we're planning to develop a consensus based on the observations that we obtain. And you will all be invited for the consensus. You will hear more about it. But the reason why I'm mentioning this project is because our initial data, when we were proposing this project for funding, was meta-analysis, a traditional meta-analysis that we performed and was published last year. So in this meta-analysis, what we did was to look for all the lupus nephritis trials ever published. And we were interested only in their placebo arms because we wanted to get an idea of how the glucocorticoids affect the outcomes when you're using the standard of care. And we define the standard of care that's using mycophenolate mofetil or using cyclophosphamide. And we included the trials who had a protocolized glucocorticoid taper. So that means that they had to follow a way to taper the steroids. Not only in some trials, it's left at the discretion of the investigator. So we wanted something that was regimented. And then that they had at least 6 months of follow-up, at least 10 patients per arm. And then the outcomes that we were looking at was complete response, defined as a proteinuria of less than 0.5, serious infections, and death. And this is a very quick overview, but we included 37 trials that included 50 arms that had a standard of care component and around 3,200 patients with lupus nephritis. As you will expect, the majority were female and the patients were around 30 years. So when trying to characterize, or we were trying to understand what is the most common practice in trials about IV methylprednisolone pulses, and what we found is, so most of the trials, 34 or 50 of the RCT arms use pulses, and the median pulse was 0.75 grams. And the most common duration was to give pulses for 3 days. So, similar to what was done in the 70s, that's the most common practice currently, at least in trials. And in terms of the oral prednisone and the tapering strategy, so of the 50 arms, 12 arms use a starting dose of oral prednisone of 30 milligrams or less, but the great majority used more than 30 milligrams. And then we also categorize if they were able to taper, or if they taper prednisone to 7.5 milligrams or less by week 16. And so basically a fast taper, and only 8 of the 50 clinical trial arms were tapering prednisone that fast. And one of the reasons why we wanted to do the 30 milligram and 16-week cutoffs is because of the voclosporin trial use very low doses of prednisone, and they taper the prednisone really fast. So we wanted also to get a ballpark of how commonly was that being done. Now, this is when it gets interesting. When we started to model the data, and we did a meta-regression and started to look at how the doses of glucocorticoids affected the complete renal response, we observed a direct dose response effect in the dose of the oral prednisone, the initial dose of oral prednisone, an effect in the complete renal response. So basically, a dose of 60 milligrams is more likely to give you, or twice as likely to give you, a complete renal response compared to a dose of 20 or 25 milligrams of prednisone. And you can see it's just a linear response. But then the pulses added a chance, or increased by 5% the probability of getting a complete renal response, independently of what was the dose of oral prednisone that is initially used. Now, in terms of side effects, so we saw also a linear dose response effect in serious infections. So defining a serious infection as those requiring antibiotics or requiring hospitalization. But a difference that we observed compared to complete renal response, when we added the pulses as a variable, we didn't see that the pulses really increase the risk of serious infections. There was no statistical difference in any of the potential doses that we included for oral prednisone. And then something that we found surprising was in terms of all-cause mortality. This is mortality in clinical trials, so I was surprised to see this degree of mortality in clinical trials. But we observe also this dose response effect in all-cause mortality. But in this outcome, the methylprednisolone pulses and those had an effect modifier effect or phenomenon. So in this case, when methylprednisolone is added to the oral low doses, it has a little effect on mortality. But when methylprednisolone is used at higher doses of oral prednisone, the mortality increases substantially. So is this difference in the effect when it's giving at low dose versus high dose that is called an effect modifier. So based on these observations that we have had so far, we are recommending to use 40 milligrams of prednisone to start, because it was the dose that gave you, combined with pulses of methylprednisolone, it was the dose that gave you the highest complete renal response. And it's also the dose that we observed that the mortality remained lower before it started to have this like rapid upstick. And this is also the dose that in the NDT review we're recommending based on this data. Now, what about long-term glucocorticoid therapy and discontinuation? So this is shifting gears, going from the initial therapy to what to do when patients have been on glucocorticoids for a while and they are already doing well or achieving remission. So there was a trial done in France, and this was patients with SLE, but 1/3 of the patients had lupus nephritis. And they included 120 patients who had been on remission and were on prednisone 5 milligrams. They had been on remission for at least a year, and then they were randomized to withdraw prednisone or to keep the 5 milligram prednisone, and they were watched for over a period of a year. And what they observed was that the patients who stopped the prednisone from 5 milligrams to 0, 1/3 of the patients had a flare, compared to only or less than 10% of the patients who remain on the prednisone who had a flare. And some of the flares were serious, so requiring hospitalizations, or many of the flares, ironically, were treated with glucocorticoids. And another thing that they described was the damage. So in rheumatology, we use this index called the SLIC damage index to measure damage from the disease or its therapies. And they only observed damage accrual in those patients who stopped the glucocorticoids and then had flares. It was a small amount, but still damage is usually something serious like a vascular necrosis or having an MI or a stroke. So it's interesting that they only observe it in those who stop the prednisone. Now, very briefly, in the review, we discussed some alternative strategies, and this in terms of glucocorticoid dosing. And this is a graph of glucocorticoid strategies on most of the landmark trials, but we included 2 cohort studies here that have used prednisone or glucocorticoids in a very different way. So one is the rituximab cohort from Liz Lightstone, and then the other one is the Cruces cohort from Guillermo Ruiz-Irastorza in Spain. And Guillermo, what he does in his cohort and in his practice is he uses the urolupus dosing of cyclophosphamide and starts patients on 20 milligrams of prednisone. These are patients with lupus nephritis. And then he gives every dose of cyclophosphamide, so every 2 weeks, he gives IV methylprednisolone 250 milligrams. So he gives that for around 6 doses. And he has described a complete renal response of 80% at 1 year, which is the highest I've ever seen reported. Now, on the other hand, the rituximab protocol or cohort was published more than a decade ago, and this was using rituximab only with methylprednisolone without oral doses of prednisone. That's why it's here in the bottom, because there were no oral doses. And every time a rituximab dose was given, so approximately every 6 months, they received methylprednisolone. And Liz Lightstone reported a complete renal response of around 50%. Now, these are cohort studies. We know that cohort studies always, it seems, observing across the board that patients in cohort studies do better than clinical trials, but it's just very different approaches in terms of glucocorticoid use. So that's why I wanted to mention them. So now to wrap up, of course, we have to discuss at least briefly the side effects of the glucocorticoids. And there are three side effects that are mentioned widely. So it's osteoporosis, the cardiometabolic effects of glucocorticoids, and of course infection risk. And this is a figure that we included in the review, and we also included adrenal insufficiency because it's commonly overlooked. Of course, a way to minimize the side effects is minimizing glucocorticoid doses, and that's easier said than done. But many times we have to keep the patients on some degree of prednisone, and in the review we outline how to mitigate these side effects. I don't, just in the interest of time and for the start to discuss soon, I won't go over all of the details here, but I want to mention hydroxychloroquine because I know that in NDT there was recently also discussion or published discussions about if all patients with lupus nephritis should be on hydroxychloroquine or not. I'm not going to go in details about effectiveness, but I want to mention some interesting side effects that maybe people don't know about hydroxychloroquine. So this is very well published that hydroxychloroquine increases the sensitivity for insulin. And patients who take hydroxychloroquine are less likely to develop diabetes. So one of the ways that you can mitigate some of the cardiometabolic side effects of the glucocorticoids is actually just by using hydroxychloroquine. Patients also, because it increases the sensitivity to insulin, they have a better lipid profile. And we know that patients who receive hydroxychloroquine have less cardiovascular disease. So I just wanted to mention that because hydroxychloroquine is very anchored in rheumatology. I know it's different in nephrology, but these are some of the other benefits of using hydroxychloroquine independently of the effects on disease activity. All right, so let's start the discussion.
Well, thanks, Ali, for this great overview. And before handing over to Kirsten, I mean, this viewpoint no to hydroxychloroquine came from your institution, but I think most of us nephrologists also love hydroxychloroquine. So I give it to all my lupus patients, and it is the main backbone of treatment, I think.
Yeah, and well, I'm not sure if it came from, I don't think it came from Mayo. I don't know, but what I can say for sure is that at least, in seeing lupus as a whole, not only as lupus nephritis, we definitely have good evidence that patients do better. And that has been repeated many, many times. Um, I'm glad to hear that you're using.
Yeah, thank you very much for these great data. You should be congratulated on this meticulous work on dissecting different glucocorticoid regimens. When I started with ANCA vasculitis, I always said I would like to have a 3 or 4 arms trial with different glucocorticoid doses that we never did, unfortunately. But I think lupus is a bit the same. We have a lot of regimens and do not really know on which basis, on which rationale to use which regimen. And you have nicely shown that the more steroids you use, the better the response is, and of course, the higher the rate of adverse events. Now, we have a lot of drugs that could probably jump into this gap that are probably not, or that have not been investigated in these trials, like anifrolumab, like belimumab, like to start off with hydroxychloroquine. Why? I would guess that not all the patients in the arms you've just shown in the standard of care arms, did they have hydroxychloroquine on board?
Yeah. And thank you for the question and for your comments. So and you're right. I mean, this is the field is moving really fast, especially in the last five years. So when we did this analysis, we only, even though we included, we have the data, for example, for the voclosporin trials, but we're not including voclosporin. We wanted at least to understand what is the effect on the mycophenolate and cyclophosphamide. In the individual patient meta-analysis, which is the next step of our current project, we have exactly the data of what patient was receiving cyclophosphamide, who was receiving ACE inhibitors, and so on, like other determinants of proteinuria. So we were not able to include that in the analysis of the regular meta-analysis. I will say like maybe 50% of the patients are on hydroxychloroquine in the trials, but when we do the individual patient meta-analysis, we will have actually the level at the level of the patient and be able to factor the hydroxychloroquine or other factors like ACE inhibitors use in the analysis.
Yeah.
Now, you mentioned the vasculitis piece, but I think vasculitis is leading the way in terms of how to use steroids. I mean, they used the Pexivas was great, that they actually were willing to try lower doses and analyze it in a clinical trial. And I think that's how it should be done.
Yes, definitely. And we must have something to sort of replace the corticosteroids, whatever that is. Now, I wonder if you read the, let's say, EULAR guidelines, they suggest a different starting prednisolone dose than the one you just suggested. Your dose is very convincing on a basis of a long analysis, but how did the EULAR decide to use the dose of 0.3 to 0.5 milligrams per kilogram per day as a starting dose, and then this lower dose, lower than 1 milligram per kilogram per day, which was used for a very long time, then this only works if you add the methylprednisolone pulses. If you do not add them, you have no rationale to reduce the starting oral prednisolone dose. How do we go about this?
Yeah, so I was debating about including the EULAR guidelines or not. I know they are being updated currently, so this might change, when they get published in the summer. But at least in the most recent update of they recommend precisely what you were saying. So very low doses of 0.3 or so milligrams per kilogram, which is basically coming from the Aurinia trials, from the trials for voclosporin. And that's their citation. And I know Professor Joachim Anders has been one of the authors of the guidelines. But one of the things that surprised me when I read them was that they were citing there's really no evidence to use a lower dose of steroids based on the Aurinia trials, because the Aurinia trials were not comparing high dose versus low dose. They were comparing patients receiving low dose versus patients receiving low dose and voclosporin. So I personally don't think that the evidence that is cited or the rationale to use 0.2 or 0.3 milligrams per kilogram is very well, backed by evidence. And that was also one of the reasons that motivated this project. Like where is this evidence? Where are these recommendations really coming from? So that's I guess my answer. I don't think it's evidence-based. That's the short answer.
Well, or at least you have to add that the low dose, probably with mycophenolate alone, is not sufficient. The trial suggests that you need something different on top of rather low dose prednisolone plus mycophenolate.
Yeah, and another thing, because we have looked at all the placebo arms, and the Aurora trial had one of the lowest responses of all the trials. But they also use lower doses of mycophenolate, and they use a very low dose of steroids, right? So the placebo arm had a complete renal response of less than 20%. So it was really one of the lowest ever.
Well, the calcium.
So yeah, it's supporting what you just say, precisely supporting what you just said.
I think the lower dose of MMF is probably due to the fact that the calcineurin inhibitor might, through metabolic interaction, increase the level of MMF. So I think that cannot be, probably not it's not a serious point of discussion, but this is difficult. Now, starting steroids is always easier than stopping steroids. When would you recommend to be at, let's say, 5 milligrams? And when would you recommend to stop? I wouldn't say at month 18 or 24, but how long should the patient be in remission until you start tapering or stopping the 5 milligram? We've seen stopping 5 milligrams abruptly is not a good idea, but you would probably taper them monthly by a milligram or something like that. But how long should the patient be in remission until you start reducing the last 5 milligrams?
So, there's no data about how to best do that. I can tell you what I do, and I'm sure there's a lot of variability. But if I'm able to keep the patients by 6 months or so of therapy on 5 milligrams, I start to taper it by 1 milligram a month. The only reason why I do that is because in the patients who have been on prednisone for a while, they just tolerate it better. They not only the risk of flares, but their well-being, how they feel fatigued and feel aches and pains, where basically the glucocorticoid withdrawal, I think, is just much better tolerated. But I don't think there's evidence or there's data about how to best do that part. But there's the reason, one of the arms of our Clean project is to create a consensus, to try to create at least a standard, maybe not the best way, or the way that is done by the majority of us, and have a benchmark for that.
That's an effort worthwhile, I think. Is it a good idea to put all the patients in one pot and define a steroid dose for all of them? I mean, I could imagine that a proliferative lupus nephritis could require a different dosing regimen as opposed to a patient with membranous or type 2 lupus nephritis. For the time being, we all put them together, we lump them together, but probably this is, again, not a wise idea.
Yeah, I fully agree with you. I think so. We had to do it this way because the way that the data is published is all mixed. So they in some trials they combine class 5 with proliferative. In some of them, like ovinituzumab is predominantly proliferative GNs. But when we do the individual patient data meta-analysis, we will do it by class. And we will be able to separate class 5. I think class 5 has even more variability than proliferative. In class 5, if you compare the KDIGO guidelines, there's to the EULAR or ACR guidelines, there's a lot of difference, like even when to treat, how to treat. So, and I know in a lot of clinicians don't even use glucocorticoids for the treatment of membranous GN. So I think definitely, like, at least within classes there should be difference.
It would be worth looking at it. I absolutely agree. Hans-Joachim, what do you think?
Maybe let me go back to the hydroxychloroquine part. When Andreas said your institution, he didn't mean the rheumatology, but the nephrology of Mayo Clinic that was promoting not to give hydroxychloroquine to everyone. But I understand that as a rheumatologist, you have maybe a different opinion. But one of the arguments was of Fernando Fervenza and his colleagues, and that I find actually a good argument, is that most of the data rheumatologists are referring to when they recommend hydroxychloroquine for everyone come from trials that were using outdated medications, so that are not using modern triple therapy, that are not using maybe even MMF. So we're from the times of cyclophosphamide et al. So how could you argue that in 2025 you have to give hydroxychloroquine to everyone when there is no data that this holds true with the medications of today? And as we speak about steroids, I would like to come with that argument also for you. You have made a literature analysis, including 37 trials of the last 20, 30 years. How does that match with a modern triple therapy? Can I really consider the same risk-benefit assessment in terms of toxicity and efficacy in view of a completely different standard of care nowadays?
Yeah. So I'll start first with the hydroxychloroquine. So I agree, and I mean, I've had a lot of conversations with Fernando. You can imagine.
Yeah.
So I agree that probably the effect of hydroxychloroquine when you are doing an induction, when you're starting the therapy, is really it's probably marginal at best, if any. I don't think it will cause a lot of difference in the first few months, but I think the effect really comes in the longer term. So, if, for example, the patients who are on hydroxychloroquine, you are more able to taper the prednisone than those who are not. And then the patients who are when you treat lupus nephritis, you basically treat everything in lupus. Like you won't see somebody with arthritis, the rashes go away. Like basically, it's so aggressive, the treatment for lupus nephritis, that usually is enough to treat everything else. In the majority of the cases. But as you start to taper the prednisone, the other manifestations start to emerge. Maybe there are some patients that only have lupus nephritis, and maybe it's not the case in those patients. And Fernando argues that somebody who doesn't have a rash or who doesn't have arthritis, why will you give them hydroxychloroquine? But in general, as you start to taper and those manifestations start to emerge, you're less likely to see them if you are having them on hydroxychloroquine. So I don't think, I mean, it's hard to take 100% like position on one side or the other. Should it be given to all the patients or to nobody? Or like that's a very extreme points just for debate purposes. I think what Fernando says, it does have a good rationale too. But I think that at the end of the day, the majority of the patients will have other manifestations, not only nephritis. And if you start hydroxychloroquine at the beginning, or you start it 5 months later, when they start to get it, at the end, I don't think it matters that much. Many of the patients will end up on hydroxychloroquine one way or the other. In terms of the doses or the time, I guess the current therapies and the triple therapy of lupus nephritis. So when we did the meta-analysis, we did adjustment for publication year, just to try to control for that. But you're right. We don't know how the use of belimumab or now of inotuzumab, will change how we will approach corticosteroids. In the consensus, we have a section where we will ask people how do they think, they will dose steroids if they are using voclosporin or if they are using belimumab or so on, because we really don't know. In the trials, they use basically, except in the voclosporin one, they use the same doses. They didn't really show or try to use lower steroid doses other than in the voclosporin trial. So I think we will have to see. We'll have to see where this goes. It's hard to tell how we will employ it.
And individualizing, probably. Let me also make you a question that uses your conclusion as a starting point, because you concluded it from the literature of the past, but now we live in a world where, at least in nephrology, the complement inhibitors are coming, And we have already learned that in ANCA vasculitis, using avacopan is a way to reduce steroids. And the funny thing is that avacopan is not even a complement inhibitor. It's an antiphlogistic drug that blocks one of the split products of the complement cascade, but doesn't inhibit complement itself. So imagine now that we get iptacopan, pegcetacoplan, maybe ravulizumab or whatever, that are potent inhibitors of the complement cascade. So would you agree that this could be an intriguing concept that these drugs could essentially completely help us to avoid steroids at all, because I think the idea why we are giving steroids is that we want to immediately block the injury that's going on in the kidney, the inflammation that's going on in the kidney. And we somehow also want to suppress the clones in spleens and lymph nodes. But for this, now we have obinutuzumab maybe, or other drugs. So I don't know if we need oral steroids for that. Maybe the pulses we could keep. But the idea could be that a true complement inhibitor would block the injury the same day. And not in 1 week or 3 weeks. And maybe in that manner, we could avoid that increase in chronicity index that we always see after 1 year in the rebiopsy studies. Yeah, this not even obinutuzumab will help us to avoid, because that works in spleens and lymph nodes and doesn't block the ongoing complement-mediated injury in the glomerulus. So I wonder, would you or Mayo be ready to do a trial, head-to-head trial, steroids against a true complement inhibitor with the ultimate aim to get away from steroids at all?
So I think, I mean, it sounds very exciting, right? Like what these drugs are promising. They are hinging in the idea that all the damage is mediated by the complement, and we'll have to see if that holds true. But I suspect, at least the idea that I have where the field is going is that at least pulses will remain. Like the first pulses will remain, and then maybe there will be no oral like arms, or at least there might be an oral arm because the patients are probably already on steroids and they need to get rid of it, which is what happened with the vasculitis trial, right? Like the patients were already on steroids and they needed to be tapered. But I suspect the field will move in to use only pulses for the acutely ill patients. Well, I don't know if avacopan or all these medications will work on day one, but we know that the pulses do work immediately, and they are also very pleiotropic and affecting at different levels. So that I suspect will be a very reasonable trial if they want to do it just with pulses and then taper it, or either transition to no oral steroids or taper it, whatever oral steroids the patient were taking.
Thanks, Ali. Another question. Again, the avacopan trial introduced corticosteroids toxicity index as one of the readout parameters, because they had already that intention that maybe their drug could be beneficial in this regard. Why are we not doing the same in lupus trials?
I think it will be incorporated. The GTI is proprietary. Is a tool that is paid for, at least for clinical trials, and I think eventually something like that, the GTI or other ways to measure steroid damage will be incorporated. There are other efforts like this organization called OMERACT that looks at trials at outcomes in rheumatology, and there's a whole area looking at outcomes in terms of glucocorticoid toxicity and damage. So I think that will be happening, sooner or later. I don't know if it has been used in any other study so far besides the one for avacopan, but it will be incorporated, I suspect.
Okay, now I have a very last question before I turn back to Gunnar. Kirsten already mentioned it, the individualization of the therapy. Not everyone is the same. You answered with the classes. I always say I don't care about classes. The drugs are all approved for active lupus nephritis, not for classes. But we have the tool of the activity index. That is something the pathologist provides us. And my question to you is how you do it personally, that now you are so much sensitized to the steroid dose question. Do you give simply 40 milligrams to everyone, or you make a difference if someone has an activity index in the biopsy of, let's say, 4 or 14? Do you dose them differently, or do you give them the same dose?
So I think it makes sense to increase the dose if you see a lot of the activity. Right now, I'm trying to stay at the 40 milligrams, except I think patients who have an RPGN picture or who have crescents, I think that's a totally different set, and patients who are very ill, definitely I go still for the pulses and keep them on 60 milligrams. But I keep coming back to this consensus. We will also ask people, like, how do you approach it when there's patients who have an RPGN picture, where it's maybe not directly related to the activity index, but is related to it's a clinical definition. But it correlates, it's usually the patients who have crescents or the patients who have very active disease. So we will be asking also how people approach the steroid dosing in that context. How do you approach it? What do you do in that situation?
You mean with the patients with the crescents?
Yeah, or with high activity. How do you think about this?
Well, yeah, I do a bit differently from you. I would say give the normal recommended dose to those with the high activity and give less to the ones with the low activity. But I know some colleagues also consider high-dose cyclophosphamide for the crescentic cases, but we don't do that. So we give the standard dose to all active ones, and maybe that are less active, we may go with a lower steroid dose or also a lower MMF target dose or taper more rapidly. But yeah, I mean, that was my question to you, because I think these are the two options. Either you step up or you step down, depending on what is your reference. But maybe also American patients are maybe per se may have a higher risk than European patients that I see that do not belong usually to this extremely high risk category. And maybe that's also an explanation why in different parts of the world one may do things differently.
Yeah.
We would have 3 final questions from our part. So the first actually goes to you, Achim. When you discuss complement inhibitors in the future of lupus, do you see them rather as a substitute for anti-20 or anti-38 antibodies that target plasma cells or B cells? Or do you see a future in which one may even combine these 2 treatments?
Yeah, I would say in the future, I hope, first of all, we don't need pills anymore for lupus nephritis, only a RAS blocker and SGLT2 maybe, but all the rest will be done with infusions, maybe a complement inhibitor to stop the injury the same day, and then to give a B-cell targeting therapy for control of disease and avoiding of future flares. The question is how long you would give the complement inhibitor, and these are all great questions that need studies to answer. But yeah, I hope that before I retire, we will arrive there and we will get away of this pill count of 15 pills per day that no one takes on the long run. And but yeah, I think it makes absolutely sense to combine the two, because the complement inhibitor works in the kidney while the B-cell targeting therapy works in the lymphoid tissues. So they have synergistic and do completely different things. So they are not redundant.
I just wanted to add that when you kill the B cells or the plasma cells, the antibodies are still circulating. I mean, you stop the production, but there's still product around, and that will take months to go away. So it's really one is not substituting another. At least that's the way I think about it. Yeah.
Then one question from the non-expert. So are there any relevant differences between prednisone, prednisolone, and methylprednisolone when giving at corresponding dosages? So I usually am used to giving methylprednisolone in transplant patients, but is there any biological difference when using them as immunosuppressive medication?
There are no real differences. I mean, prednisone and prednisolone are equivalent, and the methylprednisolone and prednisone are not exactly equivalent, but the dosing is very similar. So 4 milligrams of methylprednisolone is equivalent to 5 of prednisone. I think where you see differences are in the length of activity or the potency of the steroids. So endocrinologists, and we mentioned briefly this in the NDT review, they recommend to use short glucocorticoids that have short half-lives. Prednisone, methylprednisolone, prednisolone, all of them are short half-life, because the ones who have long half-life, like the dexamethasone, increase the risk of adrenal insufficiency. So that's really where the difference is in that, and the reason I assume our ancestors decided to use these ones and not dexamethasone, that is just a shorter half-life, and you get a little bit of a better side effect profile in terms of adrenal insufficiency.
And I have one last question for you. I mean, you pointed out the steroid adverse effects, and this is a very nice figure. So how long do you give PJP prophylaxis to your patient with lupus?
So that's another very controversial aspect. It's interesting, and Andreas, you may have seen this, but the patients with lupus have less pneumocystis, and in when you see like large databases, at least here in the U.S. databases using the insurance data, you see way less PJP, and particularly way less, for example, than in ANCA vasculitis. I will say, there's some degree of institutional culture, and I think I may give more PJP prophylaxis because we use it a lot, and a lot coming from the ANCA, from Ulrich Speck's experience with ANCA disease. I usually follow and give them a PJP prophylaxis until they are on 20 milligrams or less of prednisone. But if we're using an anti-CD20 therapy, I may keep them longer on the PJP, and especially if there's a structural lung disease. So it's not that common in lupus, but sometimes you have patients with overlapping disease that have ILD or have some degree of scarring in the lungs. So patients with a structural lung disease, I also keep them longer on PJP prophylaxis.
Thanks so much, Ali. It's so important to have experts who focus on drugs that are not really in the focus of industry, but that are so important to our daily clinical practice. And thank you also, Kirsten and Achim, for being our guest, not for the first time, but actually for being our guest since our early days back in 2021. And particularly, Achim, to you for this initiative to have these combined NDT Markus at Home webinars. And it's, if I did the math correctly, it's number 16 tonight. Thanks so much to all of you.
Thank you.
Thank you.
Thank you, Ali.
Thank you.